Thank you so much, Dr. Bose. Yeah, just a little more information on some of the latest studies that people are talking about. Much of this data was presented either at the American Thoracic Society conference this last year or a little bit before then. This data was featured prominently not just at last year's, but the year before's conference, and has to do with the Boreas and Notice studies. Dupilumab is a new treatment for COPD. It was approved fall of 2024, one of 3 new medications that was approved for COPD in the last year. Dupilumab targets IL-4 and IL-13, which are key drivers of type 2 inflammation. We have traditionally thought about type 2 inflammation as being prominent in asthma, but it's also important in COPD. And in this particular combination of studies, they demonstrated significant reductions in exacerbations, particularly among COPD patients who had an eosinophil count of 300 or more, indicating a specific type 2 inflammation phenotype. Now, there is a second type 2 inflammation drug, mepolizumab, which was also approved by the FDA this year. This is an IL-5 inhibitor, but also showed significant reductions in COPD exacerbations. This data that you see right here is MET-A. The study also included patients with 300 eosinophil count or more. This is the third drug that was approved by the FDA this year. This was maybe a little over a year ago, last summer, essentially. And ensifentrine is a nebulized PDE3, PDE4 inhibitor. And the data here shows improvements in FEV1. The drug was approved primarily based as a bronchodilator, but likely also has anti-inflammatory properties as well. So one question is, where did GOLD put these drugs in the 2025 update? Well, both ensifentrine and dupilumab were approved when this update went live last fall. But with the addition of mepolizumab, just stay tuned for a new update for this, which will be released in November. But essentially, while interestingly, the ensifentrine study did show a reduction in exacerbations, it did not primarily focus on a high-risk patient population, and that was not really something this study was designed for. And so here the GOLD committee decided to add ensifentrine along the dyspnea pathway. So we start with a single bronchodilator. Patients continue to have shortness of breath. You move them up to a dual. If they continue to have shortness of breath, even then, we add ensifentrine. For patients with exacerbations, again, we start with this basis of bronchodilators. If you have a patient with 100 eosinophil, blood eosinophil count of 100 or more, that's where GOLD is recommending adding inhaled corticosteroids for triple therapy. And then if you're still having problems with exacerbations, that's where you can consider an add-on to see what you can get for additional exacerbation reduction. Options here include roflumilast, which is a PDE4 inhibitor, actually similar mechanism to ensifentrine, but this time as an oral medication. FEV1 less than 50% and chronic bronchitis are really the patient population that's most helped. Azithromycin can also help, but doesn't seem to be as effective in active smokers. Dupilumab, most effective in patients with chronic bronchitis and eosinophil count of 300 or more. I anticipate mepolizumab will get added to this diagram soon. So just a few other studies that came out this last year. This was an abstract and actually was a pulmonary rehab, the design of a pulmonary rehab study that will be conducted in Australia. Pulmonary rehabilitation, as we know, is incredibly effective, but it's been getting harder to deliver. Patients, a lot of energy has gone into designing virtual pulmonary rehab because it's a little easier to administer, but there's been a lot of variability in the study designs and endpoints, which have made those very difficult to evaluate in terms of their effectiveness. This is a little bit different in terms of approach. This is PR delivered in primary care by primary care trained staff. The final results aren't out yet, but I'm really curious to see what this study is going to show us in pulmonary rehabilitation. Other information that came out, this was presented by Bart Chelley at ATS this last year. just talking about access issues in COPD care here in the US. I actually was fortunate to participate in a Lancet Respiratory Medicine Commission on COPD care a few years ago. And so many of these things are quite familiar to me, but as I'm sure they are to many of you, but things that many of our COPD patients continue to struggle with relates a little bit to where they live. So we know a lot of patients with COPD are rural. Um, we also know that patients with COPD tend to be lower socioeconomic status as well as lower education, which impacts a lot of things with respect to where and how COPD patients get care. We know that there can be insurance gaps impacting healthcare utilization and outcomes, as well as racial and ethnic disparities. So if we ultimately want to improve care for COPD here in the US, these are all factors that are going to have to be addressed. So this is another abstract presented by Don Mahler at ATS 2025, and talks about how inhaler technique can actually impact lung function. We spend a lot of time talking about inhaler technique, but this study I liked because it actually showed why it's important. So they found, first of all, a lot of technique common, including turning away from the inhaler and breathing out completely, holding it long enough, and then also the fact that we need to breathe in slowly and deeply for PMDIs, but breathe in quick and fast for DPIs. And it turns out that for patients who had unacceptable technique, you'll see that the FEV1 change was actually a lot worse. Pretty much all the pulmonary function measures that they did were worse for patients with unacceptable technique. So in other words, technique really does matter, and that's why GOLD recommends it be checked and rechecked often. Okay, so kind of just summarizing some of these key takeaways, we've got emerging therapies, including dupilumab and ensifentrine and mepolizumab, highlighting things that are important in terms of access to care, inhaler technique, pulmonary rehabilitation. And my hope is that as we move forward, we'll have more and more new therapies for COPD to allow us to practice truly targeted and precision medicine in COPD. So with that, I'm going to turn it back to Sonali.